Test one, one, two. Hello, test one.
Hello? Hello? Testing mic. Test one. Okay, it's all well. Thank you.
Test, 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 test. 1, 2. Testing 1, 2. Testing 1, 2. ሙከራ ድምፅ አንድ ሁለት ሶስት እንደምን አለ ሚኪያስ?
Good afternoon, everyone. I want to confirm if Greta is around. Good. So we are about to start. Once again, good afternoon, everyone. My name is Dr. Mahmoud Abdullahi, and it's my pleasure to welcome you to this breakout session here at Medical Education Africa 2026 conference. Thank you all for joining us. This session showcases a diverse of research addressing important issues in global health, medical education, public health, and health systems across Africa. Before we begin, I would like to briefly explain how the session will run. We have now five oral presentations. Each presenter has 8 minutes for their presentation, and definitely will give you a 1 minute reminder. After the first 3 presentations, we will have a 5-minute question and answer session. We will then continue with the remaining 2 presentations, followed by another 5-minute question and answer session. To ensure fairness to all presenters, I will be keeping time closely together with my co-moderator, Dr. Fiona, and we will provide 1 minute warning when the allocated time has ended. I will politely ask presenters to conclude. I kindly request that the audience members keep questions until the designated discussion periods. So let's begin with the first presenter. So our first presentation is entitled Assessing Inadequate Hand Wash and Climate Shocks on Health Outcomes Among People Living with HIV in East Africa. I would like to invite our first presenter to the podium, Greta. Welcome, Greta.
Good afternoon, dear distinguished guests. My names are Greta Mtoniwase. On background, I'm a medical doctor with approximately 3 years of experience, currently pursuing my master's in global health delivery in the One Health option at the University of Global Health Equity. So my presentation today is about intersecting challenges of inadequate wash and climate shocks to health outcomes of people living with HIV in East Africa. This is a mixed method systematic review. So despite the advances that have happened over the past 20 years globally with HIV care, there are still health inequities that persist. In Eastern and Southern Africa, 52% of the global population living with HIV accounts for people in these regions. They face a disproportionate burden compared to the rest of the world. And although 84% of people living with HIV receive antiretroviral therapy and around 80% achieve viral suppression, substantial inequities remain. And of this global population, approximately 2.2 billion people lack safely managed drinking water and 4.45 billion people lack safely managed sanitation. And these inequities compound to lead to poor health outcomes for these people living with HIV. So in relation to climate change, floods, droughts, heat waves, and extreme rainfall are increasingly disrupting the HIV care in these regions in Eastern and Southern Africa by damaging the water, sanitation, and hygiene infrastructure in these regions, who also face a disproportionate burden of the climate shocks. And this predisposes these people to food insecurity and exposes them to various infectious diseases, which leads to viral rebound in this population. And the gap here I identified, I and my colleagues, is that there are no previous systematic reviews that have been synthesized to combine the effects of water, sanitation, and hygiene, and also climate change on HIV outcomes in East Africa. And as One Health advocates, we believe that integrated solutions are required to address such problems. So on our methodology, we conducted a mixed methods systematic review using the PRISMA SR guidelines 2020. And we went through 5 databases, some which are PubMed, Medline, and so on. And we highlighted the years 2000 to 2025 because these are the years where the antiretroviral therapy was on the rise and effective in Africa. And we scoped through 18 East African countries. And on eligibility criteria, we included primarily peer-reviewed quantitative, qualitative, and mixed method studies, which evaluated WASH-related determinants and or climate-related risks among people living with HIV in East African countries. And we also excluded any reviews, editorials, gray literature, and non-English publications and studies conducted outside of East Africa. We do recognize this as a limitation of our study, as we may have missed important reports from NGOs and governmental bodies and other publications that are not in English. On screening, we found 789 records that were identified initially, and 92 records after duplicate removal. And after full text screening, we were left with 49 reports. And from these, 26 studies fit into our inclusion criteria, which were evaluated for the final synthesis of our work. We conducted a narrative thematic synthesis and interpreted it using the Africa CDC One Health framework. On results, we found that from these 26 studies, they were from 6 out of the 18 East African countries. And from these studies, 77% were primarily from Ethiopia and Kenya. And 24 out of these 26 studies focused on adults, that is above the age of 18 years old, and majority of our studies were cross-sectional. We identified various themes under these studies. The first theme being the WASH, where we found that due to water, sanitation, and hygiene inadequacies, diarrhea diseases were persisting in this population, and opportunistic intestinal infections were the most frequently reported outcomes. And through these publications that were done, WASH interventions continuously reduced diarrhea diseases. So there was a solution to this wicked problem. And water insecurity was also associated with higher viral loads and fighting illnesses. And under the theme of climate, we found that droughts, floods, and heat waves and other extreme weather events disrupted antiretroviral access and continuity of care as infrastructure was destroyed as a result of these extreme weather events. Climate shocks also increased food insecurity, mental distress, and vulnerability to WASH-related infections. Under the One Health lens, we identified a gap where there was no study that evaluated integrated One Health intervention towards the HIV outcomes in people living with HIV/AIDS in East Africa. So we found that WASH insecurity and climate-related hazards are all interconnected determinants of HIV outcomes, which do extend beyond our biomedical and management alone. Hence, it requires integrated approaches with multi-sectoral collaboration to address the HIV outcomes. Persistent diarrheal diseases and opportunistic infections, despite antiretroviral therapy, highlight the continued importance of environmental determinants in HIV care. And climate-related disruptions compromise antiretroviral adherence, access to healthcare, and vulnerability within this population. And the absence of an integrated One Health approach and intervention across all the studies reveals a critical implementation gap despite the strong evidence of interconnected human, animal, and environmental factors across all these studies. Hence, this is an area for research and other policies. On conclusion, inadequate WASH and climate-related shocks, they're interconnected determinants of health outcomes among people living with HIV in East Africa, contributing to diarrheal and opportunistic diseases and disrupting antiretroviral access. And it also reduces the well-being of these populations.
Fine.
Current evidence supports the effectiveness of WASH interventions. However, no study has evaluated integrated One Health approaches to address the poor HIV outcomes among people living with HIV in East Africa. So integrating these solutions, disease surveillance, and One Health strategies into HIV programs is essential to strengthen the resilience of HIV care systems and improving health outcomes in East Africa. And future research should be prioritized. Thank you so much.
Thank you. Thank you for that very insightful presentation. We'll keep the questions till we conclude the next two presentations. So our second presentation is about using community-based training to improve maternal health, lessons from primary health centers in rural Nigeria. This presentation will be delivered virtually. We'll give a few minutes for the presenter to connect.
Sorry, I'm here. My video is still turned off. Yeah, can I go ahead, please? My video is still turned off.
Yes, please. Can we first confirm if you could hear us clearly?
Yeah, I can hear you clearly.
Yeah, continue. You have 8 minutes, and we'll remind you for the last minute. Thank you. You can start.
Yeah, thank you. Good afternoon from Nigeria. My name is Lawal Aziz Okikiola. I'm from Kwara State University. I will be presenting on how we use community-based training to improve maternal and child health in Nigeria. So yes, Nigeria is a country that is one of the ones with the highest burden of maternal health worldwide. By a study in 2019, we observed that more than 75,000 women died of pregnancy and childbirth-related complications in 2023 globally, and nearly 1/3 of those global maternal health deaths are from Nigeria. So it is a big issue that we have maternal and child health in Nigeria. So we also have maternal mortality ratio in 1,000 deaths from 100,000 live births, which is far more greater than the less than 70 that we have from Sustainable Development Goal, which is the target of live births by 2030. So according to one of the studies that we conducted in Kwara State in rural Nigeria, only 38% of the women have been able to complete antenatal visits, which is 4. And then we compared this antenatal visit, which is 4, compared to the ones that we have in urban areas. We have more than 75% of women that have completed antenatal visits, which is this inequity is due to some of this access to healthcare. That is what we presumed it to be at the time. And we also saw that 23 of these rural births were attended to by skilled health personnel. At the time of this study, we presumed that, probably this reduction in antenatal visits is because of lack of access to healthcare and lack of provisions. But later we noticed that healthcare provisions were made, but we still noticed the negligence of these women in going to those healthcare professionals or going to these antenatal care visits in the rural area. So we noticed that this disparity is beyond that limited access to health, but it is the gaps that are provided due to provider preparedness and then from engagement with community and also the trust of the community people in primary healthcare services. Next slide, please. Yes, so why did we consider this community-based training? We consider this community-based training because in the past we've looked at traditional training and then we've saw that traditional training has limited the exposure of the healthcare professionals that we've engaged. And because it is traditional and then it is limited to the classroom alone, it did not increase the trust the women and the pregnant women have in healthcare professionals, or did it increase the service uptake at the time? So that is why we have opted for community-based training. Now, for this community-based training, we have seen studies that have provided evidence that community-based training has increased the competence of the providers because they have access and then they have on-field training and on-field exposure with their patients. And of course, it has also led to improved maternal and neonatal child health outcomes. So that is why we are looking into doing this community-based training. So the objective of this study is because we want to evaluate how this community-based training has been able to increase the competence and then the maternal and child health outcome when we look at it from the perspective of the healthcare professional, and we're also looking at it from the perspective of the mothers and the child that are given birth to at the time. So we are only considering 5 rural primary health care centers in Kwara State. Next slide, please. Now, this study, we conducted it across 5 rural healthcare centers in Kwara State, but then this engaged only rural communities like Molete, Asomu, and Elemere in Kwara State. So we only consider 3 local governments in Kwara State, which about 3,000 population of people, but then they have just only 5 rural healthcare centers in the state. So our participants, we were able to induct just only 61 nurses and community healthcare workers. They are primarily the occupants of this space. So the training components that we use for this study, because the training was for 3 months, yes. So the training components that we use for this study is that in the first 2 months, we had professionals come in to train the nurses, provide classroom training for the nurses and healthcare professionals and community healthcare professionals there. So after the first 2 weeks, the second 2 weeks, we have supervised community postings where we posted these nurses and community health workers to different homes to visit pregnant women, to visit community leaders, to visit all different kind of people at those places. So after on, we had household visits, continuous household visits with some of these patients that have been able to register for this training and then have been able to put into the work that we're doing. And we also had antenatal care follow-up, specifically with the pregnant women, postnatal care and immunization with them as well. So during some of these things, we noticed during some of these interventions, we noticed some limitations that we have, and due to the fact that we had close contact with these patients and with the community, we were able to fix those limitations and engage them better, and of course, or increase the outcomes that we had in engagement. So of course we had community leaders, we had mentorship, and we have supportive supervision from some of the learners or some of the educators that we have on ground. The training philosophy that we tried to put into our nurses and our community health workers is that we are learning with the community. So it is not that only the nurses are learning, the community is also learning. So it is a peer knowledge and a continuous process. So after the study, after the training, we had to go through the study design, which means we had to look at how far we've gone. But before the study, we had a pre-study that we gave out in form of questionnaires to both the healthcare providers and also the mothers at home to know the extent of which they have received care. And after the intervention that we had, we had a post-study that was also distributed in accordance, even though we had some persons that were absent during the pre-study and some persons that were absent during the post-study. So these are some of the limitations that we saw during the conduction of the study. So we had our outcome measure across provider knowledge and confidence. We had patient exit surveys because we had
1
ANC
minute.
attendance to
You have
track the
1
number
minute.
of people that increased beginning to the end. Then we had skilled attendance as well. Next slide, please. So we saw that our knowledge increased from 54 to 54.3 to 81%. Our confidence increased from 38.7 to 76.2%. The ANC visits increased from 42.5 to 63.8%. The attendance also. And then the immunization, it increased from 61.3 to 78.5%. So we also saw that we had increase in trust from our patients, and then the mothers reported that healthcare professionals had become more respectful. They were able to explain themselves, and then they were able to treat them with empathy. So we compared what we have with what previous studies have done, and then we observed that this community-based intervention have increased patients' trust from us and from other studies too. We also saw that in northern Nigeria, that home visit and community-based intervention, they increased ANC visits, which we also experienced. And we also saw the strengthening of the frontline health workers because they become more sustainable, and then the entire cadre of staff, they become more reliant on each other. Also, we also saw that the neighborhood relationship with the community increased as well. Conclusion, please. So why do these things matter? They matter because education has strengthened our primary health care, and it has increased our provider confidence and community trust and maternal health care utilization. So we want to also recommend, moving forward, some of the things that we saw in the study, that community-based training should be incorporated into health professionals' curriculum. We should also strengthen our partnership with universities, with primary health care centers that enable primary health care centers, so that we can also increase this training. We should invest in community health training, and then we should, have quality and SOPs for the supervision. We also should scale similar interventions across rural Nigeria so we can have more increased maternal and child health outcomes. So thank you very much for listening.
Thank you for the sharing your experiences with us. Our take-home message from this presentation is that we learn within the community, not only in the classrooms. We continue with our third presentation, which is titled Gamifying the Health Systems, Strengthening the Bloomberg Simulation Model for Adolescent Sexual and Reproductive Health Education in Namibia. So this session is also virtual, so we'll give a few seconds for the presenter to connect.
Recording in progress.
Presenter, can you confirm if you could hear us?
Yes, I can hear you.
Thank you. You have 8 minutes for your presentation, and we'll remind you when you have 1 minute remaining, so you can start.
Okay, good afternoon, everyone. I am Dr. Tuili Kanafuka from Tupa Bloom Care, an NGO in Windhoek, Namibia, and I'm going to talk about a board game. Yes, you heard right. That is an actual physical board game, and that we've been using as a frontline health system tool for adolescent sexual reproductive health and mental health in Namibia. So traditional sexual reproductive health service delivery in Namibia, as well as across the African continent, really relies on clinical as well as classroom-based model that essentially really intimidate young people as well as adolescents, and this actually results in a low uptake of services, legal counsel, as well as psychosocial support. Young people in Namibia and across the African continent, they actually need low infrastructure entry points that meet them where they are at. That's exactly what the Bloom Box game has done. So we set out to evaluate whether an offline gamified stimulation could actually improve sexual reproductive health literacy, reduce stigma, as well as strengthen active referral pathways to services. Next slide, please. So we call this a board to service model. We piloted across 16 sites in Windhoek, Namibia. We chose 10 high schools, 4 university campuses, as well as 1 youth center. Particularly, the universities were allocated to us in collaboration with the Ministry of Education, particularly the Office of the Inspector of Education. And the board stimulates real legal as well as health scenarios, which includes the Combating of Rape Act of 2000, the Gender-Based Violence Act in Namibia, as well as the came from register, facilitators logs, as well as teachers' feedbacks, and a structured post-intervention survey that was only provided to those young people at university level. So every session was formal live supervision, and even the visit to the classes, essentially, they were permitted thanks to, of course, a collaboration with the Ministry of Education, and all the facilitators had to go through a safeguarding theme to make sure that they don't have any criminal record. Next slide, please. Oh, it's there. Thank you. So the results, we engaged 1,722 youth, 1,222 high schoolers, and about 500 university students. And the feedback was really overwhelming. 92% felt safer discussing sexual reproductive health and mental health in a gamified format than in a clinic or a lecture setting. And 65 gained new legal as well as health knowledge. Specifically around the Mental Health Act, as well as the Sexual and Gender-Based Violence Reporting Protocol in Namibia. There were 0 aggression incidences during the sessions, and the 92% is really just kind of like the main headline of the finding. It really tells us that the format itself of the game is really doing what it has to do in terms of just like reducing stigma, and it's not really about the content that is being presented. Next slide, please. So overall, the Bloom Box works as a first-line triage. The game embeds referral pathpoints directly into the gameplay, and overall, it actually bridges the gap from awareness to actual care, particularly when it comes to sexual and gender-based violence, which is actually a crisis in Namibia, and where clinical settings can feel intimidating. And it does all of this with minimal infrastructure, and this is why we frame it as a health systems strengthening and not as an educational tool. Next slide, please. So to conclude, gamification through the Bloom Box is highly effective, scalable, and it really can impact the health system as essentially really strengthening it in Namibia and really across the African continent. We had the opportunity to bring this game to a conference in Kenya, and so many people who interacted the game found that the game could definitely have a positive impact, particularly to the young people that they work with in their particular organizations. So to scale, we do recommend integrating serious games into schools and as well as health curricula. And funding wise, we're looking more at funding hybrid physical to digital model. But we really want to concentrate on a physical model because one thing is clear, as much as a lot of infrastructure and conversations around digitization is happening on the African continent, the reality of it is a digital game or digital model is really going to just increase the digital divide that already exists on the African continent. And that is why a game such as the Bloom Box seems to be an excellent tool as a service delivery point, not only for policy, but not only for policy, but for education wise when it comes to health matters. Next slide. Thank you, and I'm happy to take a number of questions.
Thank you very much, presenter. You have spared us some time. Fantastic time management. Now we have 5 minutes to get some questions from the audience and discussions relating to the first 3 presentations. So if you would like to ask a question, kindly introduce your name and indicate which presenter your question is directed to, and kindly keep it brief. So the floor is yours. Yeah. Just hold on, the mic is coming.
Can you hear me?
Yes.
Thank you for the chance. So I appreciate all the 3 presenters. It's a very interesting topic. And my concern question goes to the 3rd presenter. This is an offline gamified interventional study. Especially in offline interventional study, how especially the data security managed. And the other is really, I'm not clear with the methodology she used. It's a mixed method. What type of, is it randomization or any other? And how statically measured? And the other, can you suggest really a policy change between a clinical intervention or lecture-based versus gamified? Really based on this study, can you suggest a policy change from a clinical intervention to just offline gamified intervention? Can you suggest, or do you suggest another large scale and another methodological study? Thank you.
I think that was 2 questions. Would the presenter like to respond? If you need clarification, you can state that. Presenter number 3, the last presenter. We can get another question from the first row. There was hand raised here.
Thank you for this opportunity and a great appreciation for the three presenters. Mine are comments, standing here as a senior researcher, but also as the dean at Moi University School of Medicine in Kenya. I'm really proud of the work that has been presented here, knowing that these are the young researchers that we are mentoring and are coming after us. The One Health presentation has just reminded me about the great work that we've done in the last 3 years to really open up the understanding of our students on the interconnectedness of some of the environmental factors that go beyond the human being. And so I specifically sat through this to be able to understand the concepts of how the other learners look at One Health and be able to go back home with some ideas. My research, I'm a pediatrician, and my research is both in the hospital but also in the community. By spending time with interventions at community level in maternal, newborn, and child health, I'm actually a better pediatrician in the hospital. So when I see the work done on community health and looking at how it has reduced maternal mortality, that's incredible work. And finally, I see Bloom Box triage system being one of those areas that are responding to the needs of the younger population. And we know that in Africa, I don't know about Africa as such, but in Kenya, 70% of our population is below 35. So we have a very young population who will respond to something like Bloom Box to access services and also to be able to report when they're at risk or they need services that have stigma around it. So thank you so much. Mine were comments.
Thank you for the comment. Let's come back to the first question. Dr. Tulika, if you could hear us. The first question were actually two parts. The first part was to clarify your methodology, and number two, how your findings could be implemented in real life. Was that the question? Yeah, thank you. Can you hear us, Dr. Tulika?
Oh, sorry, I was still muted. Yes, thank you so much for those questions. So just to clear up what the methodology was, so we ran a pilot study for 3 months, which was very small scale. And it was really just to test out a board game, and we also used a mixed method. So we combined qualitative data, which was the attendance count, the survey percentages, as well as qualitative data with facilitators log, as well as the teachers' feedback and field observations as well. So on the question on whether this, whether the Bloom Box can actually change policy, very excellent question. So Tupa Bloom Care as an organization in Namibia specializes in digital health as well as advocacy and research. So some of the advocacy work that we've actually done across 5 years that I'm proud to share here is that we've been advocating for the implementation of a sex offender register, and this actually is interconnected to the Bloom Box. Using the Bloom Box to sort of like educate young people, particularly those in high school and university, with regards to policy, to laws that exist in the countries around sexual reproductive health, mental health that particularly affects them, is essentially really just complementing policies that already exist. The particular game was put into high schools, into the life skills class, because Namibia has what we call a comprehensive sexual education, and the game is really an extension of that. So currently what we're doing is that we're advocating for the Ministry of Education to actually roll out the board game and have it be included in the life skills class to make sure that, that particular class, the students in that class actually do learn something. And
sorry,
some
for
of
the
the
interest
findings
of the time,
that I haven't shared here that were really interesting were
could
around
you please
just
conclude
menstrual
with your
poverty
final
in the
statement?
country, and we're working towards advocating for policy. Thank you.
Thank you. We have 1 minute remaining, actually less than 1 minute. We will take one more question. there is no question, but I have one question for the first presenter, Greta. How would your findings be adopted by academia and in healthcare facilities?
Thank you so much for the question. So our study comes to highlight a gap that's that we've observed across East Africa, and it's a call for further research and a call for policies that can address this interconnected issue that people living with HIV/AIDS in Africa are facing, where WASH interventions have proven to be effective, but standing alone without addressing the climate-related risks, they're not as effective. So it requires interconnected solutions. Thank you.
Thank you. We are moving on to our next presentation, which is on gender responsive pedagogy practices in public health colleges, Hadia Zone, Southern Ethiopia. This is also going to be presented online, so we need to just wait for the connection from Habtamu Hassan. Please go, can you hear us, presenter? Oh, it's already.
Yes, but I am Cecilia Antoinette Asma.
Okay, please.
Habtamu Hassan.
Can you hear us clear? Can you hear me?
Yes, I can hear
Okay.
you clearly. Can you hear me?
Yes, please go ahead with your presentation. You have 8 minutes, and we will stop you at the 7th minute. We'll give you a signal for 1 minute. Please, you may start.
All right. Good afternoon from Ghana, everyone. My name is Cecilia Antoinette Asma. I'm a fourth-year medical student at the University of Ghana Medical School, and today I'll be presenting a study on the determinants of intention to practice abroad among graduate entry medical program students in Ghana. Next slide, please. So this is largely a team-based effort, and I'm honored to be presenting on behalf of my team. Next slide, please. Africa faces an enormous healthcare challenge, accounting for about a quarter of global disease burden and yet only possessing about 4% of global health workforce to cater for these needs. This shortage is expected to exceed 6 million in the year 2030. We're expected to have a shortage of about 6 million healthcare workers in the year 2030. Ghana broadly reflects this challenge, having lost more than half of its medical graduates to foreign nations within the year 2009 to 2021. At the same time, healthcare workers are disproportionately concentrated in urban areas, leaving rural areas severely underserved. And this poses as a threat to equitable healthcare distribution, as well as to rural maternal health care and child health. The government of Ghana brought forward a number of initiatives to try and cater to these challenges, some of which include giving out rural incentives, bond schemes, and the expansion of healthcare or medical training. One of which includes the initiative of the Graduate Entry Medical Program. So this program was introduced in 2009 and started in the University of Ghana Medical School. It's a program that was intended to allow graduates from various disciplines attain a medical degree within a shorter period of time, while increasing the number of doctors entering the healthcare workforce. This has become widely accepted in the nation and the GEM program continues to grow. However, very little is known about this cohort of students and whether they intend to remain in the country after they graduate. Therefore, our objective was to identify the socio-demographic and financial determinants of intention to practice abroad within 5 years of graduation among the University of Ghana GEM students. Next slide, please. So we conducted a cross-sectional study involving 144 GEM students across all 4 year groups. We used the cross-sectional study so we could collect information from participants at one point in time rather than following them over a period of several years. The students completed an online questionnaire, and after that, each variable was assessed to individually to see if there was a relation with migration intention. After this, variables that showed a possible relation were entered into a multivariable logistic regression model to enable us to identify the variables that independently predicted migration intention while accounting for other confounding factors. Next question, please. So, majority of our study participants fall between the ages of 25 to 29 years old, and just over half of them are women. Next slide, please. The primary source of funding for most of our participants is family. So they rely on family support for funding primarily. We also found that about 3/4 of our participants do not have personal financial contribution to their school fees. This could suggest that the financial burden is primarily borne by the family, and in itself, it could be a push factor for migration, as students are more likely to repay familial investments on their training. So over here, with the results, we have odds ratio at 1, and that's the vertical short dash lines that you see. That's the line of no effect. So all the we have confidence intervals at 95%, being the horizontal lines. The horizontal lines that cross the line of no effect are not statistically significant, and hence we are going to focus on the statistically significant variables, which are either to the far left or to the far right of the line of no effect. In this case, we are focusing on age between 30 to 34, which is the far left of our line of no effect. Next slide, please. So we found the two statistically significant variables predictors are age between 30 to 34 years and scholarship-funded students, which are put to the far left of the line of no effect. And this suggests that these predictors are associated with lower odds of intending to practice abroad. Next slide, please. This means that students that fall within the ages or graduates within the ages of 30 to 34 years and scholarship funding students are less likely to intend to migrate out of the country. So over here, these are plausible explanations, not causal explanations, because our study design does not allow us to establish causality. So we can say the older students appear less likely to consider migration for medical practice because they would have greater family responsibilities and more stable career expectations. Scholarship-funded students would have a greater sense of obligation to the country that funded their training, and also some may have bonded funding agreements. Next slide, please. So our key takeaway message from this is that intention to migrate starts early on in medical training. These intentions are developed early on in medical training, and hence retention strategies should begin early, before graduation rather than after graduation, where doctors have entered practice. Scholarship funding and other funding mechanisms should also be used as a tool for healthcare workforce retention. Thank you very much, and if you have any questions, I'll be open to answer them.
Thank you, Asma, and my apologies, I called you the wrong name at the beginning. We have 1 minute to take a question, so we'll go straight into any questions for Asma? Okay, no questions. There's a hand just be in the front here.
Again, I think it's a comment, and looking at a young researcher delving into the area of intention to practice abroad, and this is followed up by the earlier, it's actually the right presentation after we had the debate discussing about standards. It's so related to that, and I'm glad that it's a young researcher looking at the issue of brain drain. I'm also glad that they are not looking at who has left, but actually the intention to leave. That is even a bigger objective. But again, I wish she does a follow-up study to now find out what are, beyond the scholarships that she recommended, what else are the young people telling us we should do so that they remain within our respective countries and the continent. We really need that kind of survey to really help us to support them to thrive as they practice. Thank you.
Thank you for that comment. And there you are, Asma. You had the recommendation for further to scale up your work, and we look forward to your findings. We have one more. Time is not on our side. Hemela Addis Gebre. Please come through. I will not attempt the rest of the name. Okay, so you have 8 minutes, and she's going to present on training and knowledge gaps in neglected tropical disease recognition among final year nursing students. So 8 minutes.
So good afternoon again, everyone. I'll be presenting my abstract titled, Are We Preparing the Frontline? It's a cross-sectional study of training gaps in neglected tropical disease training among final year nursing students in a single site in Ethiopia. So as an introduction, in Ethiopia, the burden of neglected tropical diseases is immense. 16 out of the 21 WHO recognized neglected tropical diseases are recognized as a public health burden in Ethiopia. And considering the current global landscape of NTD, there's a shift towards integration of NTDs into primary healthcare. Therefore, we have, I believe that preparing our frontline primary healthcare workers is very crucial to improve early detection, treatment, and referral pathways. Yet, evidence across sites in Africa, as well as across 5 different countries in Asia, report that there are persistent gaps with only 26% of students in Egypt and only 42% of students across 5 Asian countries reporting that they know the meaning of NTDs as a whole. Even among practicing workers, 75% had never received formal NTD training in Nigeria. And when we come to Ethiopia, specific evidence is lacking, and we need this evidence to know whether pre-service training is equipping our frontline workers. So this study was a cross-sectional study conducted among 60 final year nursing students undertaking their clinical internships at a peri-urban health center in Ethiopia. Convenience sampling was used, and given the single site and the sampling method used, the findings are reported as exploratory or as a preliminary finding. And data was collected using a structured survey adopted from prior studies in Asia and in Egypt. And it assessed socio-demographics, formal NTD training exposure, knowledge, and confidence scores. And analysis was performed. So within the 60 students, only 28.3% reported any formal NTD training within their pre-service training curriculum. And when we see the mean knowledge and confidence scores among these students, on a scale of 0 to 6, trained students had a 4.71 mean score of knowledge versus 2 for the untrained ones. And for the confidence in managing patients presenting with the various symptoms of the different NTD diseases, confidence was at 7.8 compared to the 5 on a scale of 0 to 9 for the students. This shows that trained students scored significantly higher on both knowledge and on confidence when considering NTD cases. In the regression model, in linear regression, formal training independently predicted knowledge, predicting 32% of the variance in the model, and both formal training and knowledge predicted confidence in detecting NTD cases, even after accounting for one another. So they predicted 45% of the variance, and variance inflation factor was checked for formal training and knowledge, since they appear to be correlated. So it was 1.6, indicating no problematic collinearity. So the takeaway is formal pre-service training was the strongest determinant of knowledge and also a key determinant of confidence among these final year nursing students. So the low training exposure, which is almost 3 students out of 10 if we consider it, it mirrors the other findings in other African countries. It's similar to Nigeria, where 75% had never received formal NTD training. This can be both class-based clinical exposure, just formally integrated into their curriculum. And trained students scored markedly higher on knowledge and confidence. This was consistent with evidence from Senegal, linking weaker knowledge of NTDs to poorer practice. And the implication of this is that embedding NTD content into pre-service training curriculum is crucial to prepare frontline primary healthcare workers, to prepare our frontline when we're going on the journey of NTD integration. And of course, this study is a single site study with a small sample, and it's meant to be, and also it includes self-reported training, not a formal audit of the curriculum. Therefore, the results are preliminary and not largely generalizable, but the findings indicate that larger multi-site studies are warranted. So to conclude, these preliminary single-site findings reveal gaps in NTD training exposure among final year nursing students in this site, and formal training was the strongest determinant of knowledge and a key determinant of confidence, which can directly influence clinical practice. And strengthening the integration of NTD content within pre-service curriculum is essential to prepare frontline providers for successfully integrating NTD care in our services. So the next steps that are recommended from this study is to validate these preliminary findings through larger multi-site studies. Okay. Thank you.
You can stay here. Colleagues, we are only going to take one, at the very most 2 questions. There's another event, departure at 5:30. So, yes, please.
I have to start by apologizing that I am that participant who has to make a comment for every presentation. And the reason is I really get excited when I see young scientists coming up, and more so for the ones who I have visited their medical school. I know your teacher, Dr. Patrick. I know your dean. I've come to Butaro. It's beautiful. And also, when you look at neglected tropical diseases, the truth is it still goes back to the standards we're talking about. If we are looking at standards and just curricula from a global perspective, we'll continue keeping this gap wider, because tropical diseases is something that is within a region and not everywhere in the world. So I'm glad you braved and did this. And I remembered there was a grant call 3 months ago on neglected tropical diseases. So I don't know if your team saw, and I don't know if, say, you are funded, but don't hesitate to apply a grant using these findings to be able to explore this further. And also to be able to really share with us. I don't know if you've published it already.
No, not yet.
Please do. Thank you.
think we have one more question in the front there.
Yes. My question is, how did you measure the confidence? Were you using a scale, or you were just asking how confident are you in the tropical, non-tropical case?
It was measured using a Likert scale, and it included different components in terms of confidence, like symptom diagnosis, differentiating between different similar diseases, like the different class of skin diseases and all of that. So it was measured on a Likert scale from 1 to 5.
Okay, thank you very much. And Dean, we appreciate your comments, very valuable. I'll ask my colleague to close our session for us.
Thank you all for bearing with us. Everyone is tired, definitely. I want to appreciate the Dean from Moi for her comments, guiding the young scientists to, improve their work and encouraging them to publish. I couldn't capture your name, sorry. There is a little bit of announcement coming from the organizers. As you all know, today we are concluding with an invitation from Ministry of Health Ethiopia. I think that's a dinner reception at Arada Park. So it is outside here. So we are stepping outside for those who haven't stepped out yet, like me. So buses will be waiting at the place where we received our badges this morning. They said it is indoors, but this morning they warned us that the weather could be actually chilling and cold. Yeah. Thank you. Thank you all.